Thank you all for being here. I'm Sarah. It's nice to be able to talk to you guys about our program, which I feel really passionate about. The goals of the DD program at Skyland are aimed to support clients in identifying the link between mental health and substance use for themselves, moving through the stages of change, and developing a skill set that they will be able to utilize long term that will support them in being able to build their life worth living. There's a pretty wide range of client attitudes about the DD program because there is such a wide range of clients who end up in the DD program. And so the stance of myself and the other DD core leaders and PCs is really to try to meet clients where they're at, allowing it to be an information gathering process, really doing that classic rolling with the resistance, exploring what the threat is. There can be a lot of protection and grief when it comes to clients exploring what their substance use history has looked like, supporting clients and getting honest with themselves and their support system, and kind of identifying where they're at in the progression of substance use disorders is a really big treatment task. Providing quality psychoeducation is also one of our big goals. There is simply a lot of misinformation out there. There's a big vacuum of information. I think that there are still quite a lot of cultural myths right now that both clients and families buy into around, the sort of self-medication narrative or this is plant medicine and this is helping me. And so a lot of the times client motivation to change and insight into the severity of their substance use disorder doesn't come until the consequences have started mounting and there is a good amount of neurobiological dependence. Clients in the DD program also need additional support in maintaining abstinence because of that increase in psychiatric symptoms that Ashley was talking to us about. Many of our clients are experiencing post-acute withdrawal symptoms, so that emotional lability, irritation, poor stress management, in addition to their psychiatric symptoms. And a lot of the times have no idea that that is what they're experiencing and just feel pretty awful at the beginning. And so support, education, connection to a recovery community, getting involved in 12-step programs, and developing a personal relapse prevention plan that's going to be helpful to them in the context that they return to post-treatment are all the things that we're trying to do with clients. So clients are in their DD core group 4 times a week. They're often matched with a DD core group who is different from their PC so that they have the ability to connect with multiple people on the treatment team to explore these recovery principles. A big part of DD Core is about providing that quality psychoeducation, not just about the link between mental health and substance use, but also just how does addiction progress in general? What are the warning signs? How are our relationships impacted? Physical health, values. In DD Core, we're also bringing in application of skills from the evidence-based modalities that Skyland Trail uses and helping clients apply that to their overall recovery. DBT, for example, has an entire set of distress tolerance skills when the crisis is addiction that we teach in DD Core and our relapse prevention skills group. There's lots of great application of CBT skills for recovery. In general, I could give you a principle by principle overlap between 12-step and clinical programming. I will not do that. That could be a whole other 45 minutes. The other things that DD Core is offering clients is connection to community. The nice thing about core groups is that clients enter into a core group and then they stay there through their entire time at Skyland Trail. So the same 8 to 10 clients may have a day 1 client, a client right in the middle, a client preparing to step down to a recovery residence, a client preparing a discharge who's working with a sponsor and is really motivated in their recovery. So in addition to hearing information from the group leader and their PC and sort of grappling with the information themselves, there's a lot of peer modeling and peer accountability. I'm sure you would believe that it matters a lot more to have a peer sort of challenge distorted thinking and call clients out than us doing it. And so I think the power of the DD program at Skyland Trail is in the recovery milieu we have and people really buying into the recovery model. And finally, DD Core opens up a space where clients can begin to share and open up in a safe setting We ask clients to share their DD timelines. So this is an assignment that's based on the exploration of how did my substance use and psychiatric illness sort of develop through my lifetime. It's a helpful way to see this sort of escalation of both and that they are connected. We do a lot of values work and goal setting with DD clients, trying to move them into identifying their own motivation for overall recovery and feeling more empowered in sort of like changing their narrative and changing their course moving forward. In individual sessions, we are also integrating the primary mental health track modalities with substance use interventions like motivational interviewing. So the primary mental health track is really determining the feel of individual sessions. A DBT-DD client, for example, is getting all of the benefits of adherent DBT therapy, the structure, the foundationally trained clinicians, the diary cards, everything like that. And substance use is being interwoven through that, thinking about functional analyses and BCAs and diary cards and impulsivity. Same with CBT and CAFE. So our DD clinicians are really adept at using all of the clinical modalities that we use at Skyland Trail and keeping an eye on the big picture for clients. This is really, really important. And I think like one of the most helpful parts of the concurrent treatment we offer at Skyland Trail, because we are sending the message to the client that we see that all of this is connected. We cannot treat one without the other because it is all the same client, brain, nervous system, because we want treatment to be effective and really targeted on the full person. Something else that we do in our DD program at Skyland is ask clients to attend 12-step programs like Alcoholics Anonymous, Narcotics Anonymous, Marijuana Anonymous. This is an area that can kick up a lot of reservations for clients and families at the beginning, especially if people do not have exposure to 12-step fellowship. The nice thing about 12-step is that it is really based on a community model of ordinary people supporting ordinary people through sharing their experience, strength, and hope. Fellowship, community, really like helping clients and develop a whole community based around recovery and not sort of solely focused on substances, which is so normalized in our society as like the anchor point for socializing. It's a great complement to therapy because it provides something that therapy quite simply cannot. Like, this is my specialty area. I love dual diagnosis work. And because of my licensing, I don't share anything of my own experience. Clients get like 5% of my personality in groups and sessions. And that is what makes therapy helpful, to have the focus be on the client experience. And oftentimes clients want to hear from somebody who's been where they're at, has done the same behaviors, has had the same struggles, and has gotten through to the other side and is willing to sort of share in depth about how that looked for them. It can really inspire hope, reduce stigma, and it's really effective. We see great outcome scores from clients who engage in 12-step fellowship. A lot of the times in the residence, we're asking clients to attend what we call open meetings. So clients do not have to identify as addicts or alcoholics to attend 12-step meetings. It is often clients' first exposure to this type of like fellowship aspect to recovery. These meetings are non-religious in nature. Clients do not have to be religious to attend or participate. They are based in 12 sort of like humanistic spiritual principles like hope, fellowship, integrity, courage, stuff like that. And there's a lot of opportunities for agnostic and atheistic meetings if that is more reflective of a client's belief systems. This also ties into the aftercare recommendations. Skyland Trail is just one piece of the puzzle. And so when we're thinking about helping clients prepare for discharge and what that critical period of like the 90 days post-discharge looks like, 12-step is a big part of it because it's free, it's accessible, it's everywhere. Having clients get tied in with a sponsor or a mentor, a home group, doing 90 meetings in 90 days, going through the 12 steps themselves, it is such a rich resource for them. And it enables clients to integrate the skills that they're learning at Skyland Trail and also practice a lot of the skills they're using. I mean, talk about an exposure hierarchy. If a client with social anxiety whose drug of choice is alcohol is being tasked with asking someone to be their sponsor in a meeting, that is such a rich practice opportunity. And that stance, blending the clinical and the recovery model, is what we're doing all the time with clients. When clients step down from residential, we, like Ashley said, require that they step down into a recovery residence, which they are often calling a sober living. This enables us to support them with that big accountability piece when clients leave the residence or are in the PHP program from the start. Their risk of relapse is really high. There tends to be a big overconfidence in client ability to maintain sobriety when they are doing the intensive therapeutic work that they are doing here and navigating stress, change, independent tasks. Relapse is pretty high. Cravings can come up unexpectedly. And clients tend to early on in recovery put themselves in pretty high risk situations. And so having the accountability and support of a recovery residence where they're supported in attending and finding daily meetings, connecting with other clients who are in recovery, living in a place where there are no drugs or alcohol present or permitted, there's a curfew, not as much oversight and structure as 24/7 residential treatment, and it is much more oversight and structure than clients typically have outside of a recovery residence. It also has the nice perk of taking their family members out of the role of trying to be their recovery coach. We don't want mom of an adult client, drug testing adult client. We want mom to be able to focus on being mom. It can be a really crucial window of time. What I tell the family members who are unsure if they would like their loved one to do the PHP and IOP portions of treatment is that this is where I see the most generative change for clients, because residential is about stabilization and building a skill set. But step down is really when clients are stress testing their skills, applying it to diverse environments, and working on building out their independence long term with support of the treatment team that has knowledge of them and kind of knows their trigger points and has seen them through this far. It can be a really helpful and important part of treatment. So overall, we are trying as much as we can to integrate DD within the larger program. There's a lot of concerns, especially through the admissions process early on in treatment, that dual diagnosis is taken over, or it's going to eclipse the mental health part of treatment, or it's going to erode client motivation for recovery. Instead, what we see is being able to speak to the difficult emotions that are coming up in early recovery and equipping clients with skills and insights early on. It can increase client buy-in to recovery because they are not alone in struggling with it. They have support in managing cravings. And they tend to sort of be able to see the bigger picture. And through working with them and building the therapeutic relationship and validating the threat, validating the difficulty, and helping them see the connection with their overall clinical modality, clients can go quite far in this type of program. And long term, we're trying to reduce the sort of like program to program whack-a-mole, where you do some of it here, you got to do some of it somewhere else, the revolving door of treatment. Like, we really want clients to be able to recover and get back into a more independent level of care, get back with their support systems and get back into their life. And this is much more effective than sort of like sequential treatment.